Bueno, buenas tardes.
Hello, good afternoon. Let me introduce myself. I'm Dr. Losa, and I work at the Sagrada Familia Clinic. I'm a gynecologist. And in these very terrible days that we're all going through, I am organizing some webinars in the morning, in the afternoon, in the evening, even at night, because we've had webinars with South America as well. And I would like to thank you all for being here today at 3 o'clock in the afternoon. And I would also like to thank Procare, the pharmaceutical company sponsoring this webinar. Today we'll talk about one of their products, their iron product, because the topic of today's webinar is anemia. Anemia is a worldwide problem. It's also a pandemic, different from the COVID-19 pandemic, but it is a problem that is underdiagnosed and understated. However, it's very easy to diagnose and to treat. So we are going to start talking about iron. As you know, it's a key oligoelement in the erythropoiesis process, in the formation of red blood cells, of hemoglobin to transport oxygen to the body. And for this erythropoiesis process, we need also the right amount of vitamin B9 and vitamin B12. In the body, iron is present mainly in the hemoglobin. Up to 70% of iron is present there, and 10% is present in other hemoproteins, such as the muscle hemoproteins. There are two different types of iron. The heme iron, that's the animal origin iron, that shows a better absorption, and there's the non-heme iron, that is a plant origin iron that has a worse absorption. With regard to the iron levels, the daily intake should be 15 to 20 milligrams. And we know that out of this amount, 5 to 10% is absorbed. And it's important that the iron absorbed is balanced with the iron loss. If not, we start seeing iron deficits in some parts of the body, in the muscles, in the formation of the red blood cells. Therefore, it's very important to maintain this balance between the iron absorbed and the iron loss. Anemia is defined as the reduction of the red blood cell count in an individual. According to the WHO, it's the condition where the number of red blood cells or their capacity to transport oxygen is insufficient to meet the physiological needs of a person that vary according to age, gender, altitude, and other circumstances such as smoking or pregnancy. In the clinical practice, anemia is diagnosed according to the hemoglobin levels and also the red blood cell count and the hematocrit level. And the levels vary from women to men. In women, the hemoglobin levels in the case of anemia would be below 12 grams per deciliter. The red blood cell count would be below 3.8 and the hematocrit level below 35%. It would be slightly higher in men. Anemia is classified according to the red blood cell morphology. Today we'll be talking about iron deficiency anemia, and this is a microcytic type of anemia, so the red blood cells are smaller than in megaloblastic anemia, where their size is bigger. In microcytic anemia, we can see different values such as high transferrin and high ferritin with high reticulocytes, and that would be an indication of thalassemia. If we have high transferrin and low ferritin, then that would be an indication of iron deficiency anemia. And normal transferrin or low transferrin with high ferritin, it could be an indication of a chronic disease. And if we have low blood iron and ferritin between 20 and 200, we would see this as an indication of iron deficiency anemia and with a concomitant chronic disease. The prevalence of anemia is high in children, but today we'll focus particularly on women of childbearing age, where it's 30%, and pregnant women, where it's 40%. In the elderly, we also see a high prevalence of anemia due to the poor iron absorption. According to the WHO, there are 400 million people with anemia in the world. That's 15% of the world population. The prevalence in Spain is the following: 20% in women of childbearing age, 40% of pregnant women, and 15% of adolescents. The causes of anemia are the following: firstly, pregnancy, breastfeeding, adolescence, growth, sport. Most athletes take iron supplements, stress situations, the loss of blood due to menstruation, AVB, childbirth, and other types of bleeding, digestive bleeding, or due to injuries, and insufficient intake due to insufficient diets, vegetarian diets, or food disorders where there's a poor iron absorption, and there may be other absorption problems due to diseases such as Crohn's disease, or there can be a combination of the above factors. The most vulnerable groups to anemia are children, adolescents, women of childbearing age, pregnant women, also athletes and vegans who don't have the heme iron that's easier to absorb. This is the period of life in women where we see more anemia. That's between the ages of 24 and 40, because that's when they have the menstruation. That's when we also see pregnancy, and during pregnancy there are different needs that are related to iron, and the prevalence in the menopause is lower. The consequences of anemia during pregnancy can be an impact on the growth of the baby and an impact on their cognitive and psychomotor development, and anemia in pregnancy can also be associated with perinatal mortality. The number of women with anemia in Spain is seen on this map. We see that in Catalonia the level is more or less okay. It's higher in Valencia and in Castilla-La Mancha. But what we do know is that in Spain, 40% of pregnant women suffer from anemia. And many of the vitamin supplements that we prescribe during pregnancy include iron. With regard to the treatment, we should start with the diet recommendations so that we can increase the consumption of food that is rich in iron, such as meat, fish, eggs, vegetables, and we should avoid the consumption of iron inhibitors such as coffee and tea and even some drugs. Iron is administered through two main pathways, oral and IV. In the past, in fact, there was also an intramuscular iron form, but it was more painful and caused some staining. And the most frequent form is the oral iron, and we use ferrous salts that are more bioavailable and ferric salts that are less bioavailable. The dose of elementary iron would be 100 and 200 milligrams, the duration of the treatment 3 to 6 months, and as you know, the absorption would be 15 to 30%. In these cases, we always recommend to prescribe the oral iron together with vitamin C that helps with absorption, and to avoid the iron inhibitors that I mentioned before. There are many tables with lists of iron-rich foods, for example, clams and mussels. This is another table where we see the iron values of different types of food. Fish, calamari, for example, have a value of 3.9. Then we have cereal, breakfast cereal show a value of 12. Lentils are also rich in iron, but not as rich as people usually think. But they are rich in iron anyway, the same as quinoa and pistachios. There are many different types of food that are rich in iron, also fruits such as peaches and apricots. In the case of eggs, we see that quail eggs have more iron than chicken eggs, and brown bread has more iron than white bread. With regards to the treatment, it's important to start with the patient's history to identify the causes, to be able to correct the anemia, because sometimes the anemia may be due to a hypothyroidism. In that case, if we treat it, we can improve the iron levels. Ferrous salts are in different formats, such as ferrous sulfate, and later on I will talk about liposomal iron so that we can look at the characteristics and benefits that it provides versus other therapies. Once we start the iron treatment, we have to assess the hemoglobin at 2 weeks. It should increase 1 gram at 2 weeks and 2 grams at 4 weeks. If the response to the treatment is appropriate, we should continue with the treatment to normalize the hemoglobin levels and the iron reservoirs. However, in some cases, we see that there are women who are refractory, who are receiving iron, but there's no improvement of their hemoglobin levels because there is an intolerance or because they are refractory. And in these women, that can account for 68% of the patients, we can consider the possibility of prescribing liposomal iron or prolonged release iron. The iron deficiency anemia associated with pregnancy is seen in 40% of the patients, and the first line of treatment would be oral iron, the ferrous sulfate that we have been using forever. But we can also consider these other types of iron, the liposomal iron and the prolonged release iron. The second line of treatment would be intravenous iron if there's no improvement, if the hemoglobin figures decrease and patients start suffering from fatigue, hair loss, and other symptoms, particularly when we're talking about pregnant women, because we want to avoid any impact on the baby. So, intravenous iron is necessary in some cases to avoid any negative impact on the baby. This is an algorithm of the treatment of anemia in pregnancy. During the first term, we will prescribe the sulfate at 2 weeks. We will assess if there's an increase of the hemoglobin levels. If it has increased and there are no side effects, then we will continue with the treatment in the second term. If the hemoglobin is above 9 or below 9, then we have to look at the different options. If it's below the necessary levels, we should consider the use of intravenous iron. If with the intravenous iron, the hemoglobin levels are normalized, we can switch back to oral iron, and if the levels continue to be normal, we can continue with the treatment. But if the increase is below 1 gram, and there is no improvement, not even with the intravenous iron, then we should consider the possibility of a blood transfusion if the hemoglobin and hematocrit levels are very low. In the treatment of iron deficiency anemia, we have different situations such as cancer patients and also post-COVID-19 patients, because patients who have suffered mild or severe COVID have anemia. Therefore, it would be very interesting for these patients who have suffered COVID to treat them with iron. We also see anemia in patients with kidney failure and heart failure, also in rheumatology patients and in pediatric patients. We see that anemia is also present in children and also in patients with GI disorders such as inflammatory diseases. I will not explain now the treatment of these underlying diseases. We are not going to be managing the hormone therapy or the chronic dialysis, so I'm going to skip this slide. However, if you are interested in having the PowerPoint of this conference, please request it. All right? Just so you know. What's very important in our patients when they're taking iron is the adverse events that may emerge. Particularly when we prescribe sulfate, the ferrous salts can cause side effects, and in the long term they can even cause coloring of the teeth, nausea, vomiting, stomach gases, and this metal taste in the mouth. In some cases, we also see diarrhea, constipation, and abdominal pain. There may be an increase of pathogens and tissue damage, an increase of oxidative stress due to the iron that is not absorbed, and this leads to ferroptosis, and this can cause GI dysbiosis due to the increase of the oxidative stress with a destruction of the cells in the duodenum. That's where iron is mainly absorbed. Coloring of the feces, and we also see drug-drug interactions with tetracyclines and other antibiotics, with antacids, with biphosphonates, and there may be interactions as well with tea, coffee, dairy products, because calcium interferes with iron absorption. And in these cases, we should separate the iron dose administration from the meals, but then there can be a reduction of the absorption, and this will lead to a treatment failure. And there are many patients as well that discontinue treatment due to the side effects, because these adverse events are due to a Fenton reaction. We have divalent atoms that can create hydroxyl radicals that are very, very difficult to eliminate and cause lipid peroxides that will increase this programmed cell death that is iron dependent. This apoptosis is different from other apoptosis that we may see, because this apoptosis is due to the free radicals that cause some oxidative damage in the cell membranes. That is very often mediated by the lipid peroxidation due to the arachidonic acid, and its increase may activate the creation of free radicals and inflammatory processes. This will have an impact on the DNA and the proteins. and it will affect many of the cells in the duodenum and can cause some gut permeability that can lead to many other problems due to the adverse effects of the lipid peroxides that increase the ferroptosis, cause the nausea, the stomach gases, the metal taste in the mouth, and the tissue damage due to the increase of oxidative stress. Additionally, it can have a negative impact on the gut microbiota. On this first image, we see a healthy microbiota that is working properly, where there are no problems. However, due to the oxidative damage, we see an adherence of the pathogens that is higher, pathogens such as Salmonella and E. coli, that will be displacing Lactobacillus and Bifidobacterium. And this will create a dysbiosis that will lead to different diseases. So in short, traditional iron, these iron salts have a low absorption, a low GI tolerability. They increase oxidative stress, they can cause food interactions and drug-drug interactions, and also cause a dysbiosis of the gut microbiota. We will now talk about the iron absorption. It's a complex process, but I will explain it briefly. We will see how non-heme iron is always in the form of iron 3, and it needs to be reduced to be able to cross the apical membrane. For this, it needs an enzyme, a ferrireductase, that will help then with this reduction and through a metal carrier, it will penetrate the cell and will bond to the ferritin. Non-heme iron can also use another pathway through mobile-ferrinin and paraferritin, but in this way, we will have the same type of absorption. Heme iron follows an easier pathway through an enzyme, through a hemocygenase that will convert it into iron 2 into its ferrous form so that it can bond to ferritin. So once the iron is absorbed and has bonded to the ferritin, it will go to the blood through transferrin, and it needs to oxidate again so that it becomes again an iron ion through halafastine or suruloplasmine. And in this way, it will reach the bone marrow, the liver, and all the other parts of the body, the muscles, all those parts in the body where iron is needed. In this process, hepcidin is the peptide that controls the absorption and the transport of iron. It is manufactured by the liver, and it has an action on a protein called ferroportin, and it regulates the levels of iron, it regulates the erythropoiesis, and it regulates also the presence of inflammation. So the synthesis of hepcidin is reduced when there's an overload of iron and when there are infectious or inflammatory processes, and hepcidin will increase when there is an iron deficiency. There are several factors that activate or inhibit hepcidin. For example, blood transfusions, iron administration. Different variants of this gene can also activate hepcidin, and it can be inhibited by anemia, erythropoietin, and the plasma level of hepcidin is proportionate to the level of ferritin in the blood. There are new technologies that help with the bioavailability and the absorption of iron, and that reduce the side effects. We have liposomes that are used for many drugs, and a liposome is a round membrane of a phospholipid nature that is very similar to that of the cell membranes in the human body. So it's easy for them to bond with them, and in that way you don't need the mediation of so many enzymes or mechanisms of action. What is the advantage of the liposomal technology? Well, it protects the GI mucus from the oxidative action of iron, it minimizes the adverse events, and it increases the absorption of iron in the gut, and it offers a better bioavailability of iron in the body. The mechanism of absorption of liposomal iron is different from that of traditional iron because the absorption is done through the M cells that are in the wall of the duodenum that will be bonding to the macrophages. So in this way, it reaches the lymphatic stream, and the macrophages through endocytosis, not through the hepatic bloodstream, but through a lymphatic pathway, they will reach the liver, where the liposome will be freed and the iron will be free. It will be totally bioavailable for the bloodstream. And if we have a product with liposomal iron that also includes other ingredients, such as fructooligosaccharides, that's a prebiotic that favors the absorption and improves the GI tolerability of iron, because some liposomal iron may break early and free the iron, and this could have a ferroptosis effect. So it's important for these liposomal iron products to include fructooligosaccharides as well as vitamin C that help reduce the fatigue and improve the iron absorption, that iron that has not been totally absorbed by the M cells. And this product also includes folic acid, then it improves the cell multiplication and division. We always prescribe folic acid to pregnant women, and another important ingredient is vitamin B12 that contributes to the normal formation of red blood cells and erythropoiesis. All this will contribute to increase the bioavailability, the absorption, and the tolerability of iron. Several studies have been conducted. There's this study with mice that assesses how iron reaches the liver and how it's distributed from the liver. The study was done with liposomal iron with lipofer, and these parameters were assessed with regard to iron absorption and bioavailability and how the iron reaches the liver and other parts of the body. A very short study, a one-day study, comparative study, was also conducted to look at the absorption versus sulfate, iron sulfate. The patients were divided into 3 groups, and the hematocrit and hemoglobin just in one day increase their levels with the liposomal iron. We see better results in the liposomal group. Liposomal iron is a good strategy to prevent iron deficiency in humans. This study was a limited study in number of patients and in duration. However, here we have a randomized study with women between 18 and 35 years of age. This was a longer study, and the hemoglobin and other aspects were assessed, and we see a difference versus placebo, a significant difference in the group that was treated with liposomal iron. Therefore, the optimal dose would be 40 milligrams of iron, and in a short period of time, with a small amount, we see an improvement in all the parameters. By way of conclusion, with regard to this food supplement based on a liposomal iron with an innovative technology, it includes fructose oligosaccharides, vitamin C, vitamin B12, and folic acid, and it shows a triple improvement because there's a better absorption, a better tolerability, and a better bioavailability. This product is oral dispersible. It has a very nice flavor. It's very easy to take, and it has a very good tolerability. Questions? What's the difference between iron deficiency anemia and iron deficit? Well, in iron deficiency anemia, we see a reduction of the hemoglobin levels of red blood cells, whereas in iron deficit, we have a reduction of the iron in the bloodstream. However, iron deficit is often seen as anemia. Iron deficit is more frequent than anemia. Are there any comparative studies that compare IV iron with oral liposomal iron? Not as far as I know, no. Because IV iron, as you know, has a very rapid onset of action. We are solving the problem very quickly, but we are always reluctant to hospitalize a patient to receive Ferinjet or Venofer to give them IV iron. And we prefer to try other types of iron. I think that liposomal iron, well, has no comparative studies, but it does have a rapid absorption and bioavailability. So I think we can give liposomal iron before IV iron. And what type of patients would you recommend this liposomal iron to? Well, usually we prescribe the sulfate because it's much cheaper, but between 30 to 40% of women in pregnancy will start having adverse events, side effects such as diarrhea, abdominal pain, and then I try and give them the liposomal iron. And the same happens with athletes because they can take liposomal iron at any time of day. They don't have to combine it with meals. Although I don't recommend to take iron at night because it can cause some insomnia. What's the difference between the absorption of liposomal iron and the ferrous or ferric salts? Well, the liposome adheres to the cells, to the M cells, And in this way, they go straight to the macrophages and it reaches the liver through a lymphatic pathway and it goes straight into the bloodstream. So the mechanism of action is different from that of the traditional iron forms. What's the maximum dose that you would recommend for the second term of pregnancy? Well, I would give maximum 2 tablets. That would be 28. Because the iron that is not absorbed is free in the body and that has an oxidative effect. Just look at iron when it's outdoors, it rusts very quickly. There is a quick oxidation, and free iron in the body will lead to free radicals. What's the amount of folic acid that this product has? Well, it's 200 milligrams. It's not like other folic acid products because this is a product to treat anemia and it has 200. Can it reduce all the GI side effects? Yes, liposomal iron will make these side effects disappear in 99% of the cases. Maybe in some patients, due to their GI acids, some of the liposomes may break and some of the iron may be free in the body. Liposomal iron is your first line of treatment? Well, yes, but it's a bit more expensive. I think it should be the first line of treatment because it's better than the classical forms. But this one is more expensive. The traditional ones cost €1 or €2. So, if you want a rapid onset of action, I think it can be your first line of treatment. I do think it's a very well balanced product with folic acid and vitamin B12. Next question. Sucrosomal iron is the same as liposomal iron? Well, they are virtually the same. Instead of using phospholipids, it uses sucrose, but it's still a liposome. But sucrosomal iron has, well, as I said, a different aspect in this regard. 14 milligrams is enough for a strong treatment. Well, you can give double the dose, but you have to think that liposomal iron is absorbed 100%. When you use the ferrous salts, then you only have a 15% absorption. So remember this. Liposomal iron is absorbed 100% because virtually 99% will be adhering to the M cells and it will go through the lymphatic pathway to the liver and to the bloodstream. So if you are afraid that 14 milligrams is insufficient, you can prescribe 2 tablets, then we'll have an increase of vitamin C amounts. But we are all taking vitamin C during these days due to COVID-19, so it's okay if there are 150 milligrams of vitamin C. That won't be a problem for the baby or anything. You mentioned that you would recommend liposomal iron, well, iron for COVID-19 patients. Well, yes, because I have worked in the COVID-19 ward and we see this inflammation cascade with interleukins. And in COVID patients, we see very, very low levels of ferritin that I have never seen before. The ferritin levels are involved in the inflammatory process, and many red blood cells go through this hemolysis. And the red blood cells are very much reduced. And patients who have suffered COVID have had anemia for sure. If we did a blood test, we would see that their hemoglobin levels are low because there has not been time for them to replace their hemoglobin levels. And for these patients, I would give liposomal iron because this liposomal iron doesn't cause these free radicals or fewer free radicals. Do you recommend it for anorexia? You know how special anorexia patients are, but this is a stick type of format. It's oral dispersible, and I would just recommend one dose, not two. And are there any problems with diabetes patients? Well, there's no problem because with fructooligosaccharides, we see in different studies that there's an improvement of the gut dysbiosis, and this improves the insulin requirements. Therefore, there are no problems, no contraindications for diabetes patients. You know that fructooligosaccharides don't have a high glycemic index. They are used by the gut bacteria to grow. They feed bacteria. They are a prebiotic. Is liposomal iron available as a parenteral administration? No, not as far as I know. There are 2 liposomal iron products available, but they're not IV. And at 3 hours, liposomal iron shows very high levels in the blood. It has already gone through the liver. So liposomal iron in a way does go straight to the bloodstream. Next question, are they tablets or are they sachets? Well, they are sticks, they are oral dispersible sachets that have a really nice flavor. If you try it, you see how nice the flavor is, and it doesn't leave this metal aftertaste that you get with other type of or iron products that are available in different formats, gels and others. All right, can the current iron treatment be replaced by the iron care treatment? Well, of course, you can switch from one to the other, and they are compatible, in fact, because they have 2 different absorption pathways and bioavailability pathways. Would you recommend iron care for postmenopausal women? And is the dose enough? Well, the WHO recommends a dose of 14 milligrams, so this is the recommended daily dose. And this is not taking into account the food that we eat, vegetables, and, for example, salmon, that is very rich in iron, or red meat. But if you have a vegan patient, a postmenopausal vegan patient, then maybe she would need a higher dose. But I think 40 milligrams is more than enough. The thing is with doctors that we always want to prescribe products that have an immediate action and that are very good and cheap, and sometimes we increase the dose unnecessarily because if the dose is too high, we have the problem of oxidation. Would you recommend iron care for athletes, and what would be the dose? So what's the dose recommended for athletes? That's a very good question. Athletes consume a lot of iron. They consume the myoglobin in the iron. And I do think that one dose would be enough. However, if you have an athlete that has low hemoglobin levels or who has trouble recovering after their standard training, or they have oxygenation problems, then maybe for some days we can increase this dose. Maybe we can give them double the dose for 15 days and then a maintenance dose. Next question. Are there any interactions, drug-drug interactions that we should take into account? Well, yes, there are some drug-drug interactions with some antibiotics, such as tricyclines, but there have been no studies done with this iron, but with traditional irons, we know that there are some drug-drug interactions also with tea and coffee that can interfere with the absorption. However, with iron care, we see a different type of absorption. So maybe there's not this type of interaction with the iron absorption.